It is my pleasure and honor this night to have this gathering from the Arab world and from Egypt. Today, this is a very special night because it is not a classic presentation. It is a case followed by discussion. This night we have Professor Magdy El-Sharkawy. He is a well-known figure in Egypt, in Arab world. He is a professor of internal medicine and nephrology at Ain Shams University, and this is the prestigious school of medicine in Egypt. And Professor Magdy is characterized by the best attitude in dealing with patients, dealing with his colleagues. Always we learn a lot from Professor Magdy El-Sharkawy, and he is talented in both education and dealing with people. So I am sure this night will be exceptional, interesting, and he will moderate this session. Professor Wesam Ismail is well known because she enriched the Academy of Kidney Disease and Transplantation by more than 30 hours of all nephropathology. And I think her presence with us this night will enrich the case as a comment, and she will fortify the case by some illustrative pathology slides from her own. I'm leaving the mic to Professor Magdy El-Sharkawy to present Dr. Medhat El.Awady. He is the chairman of the nephrology department at Wadi Elneel Hospital, and this is the first time for him to share us in these activities. So I'm leaving the mic to Professor Magdy to run the session and then to go ahead. Professor Magdy.
Thank you very much, Professor Hussein. This is a very kind introduction, and I think it will be a wonderful night with my dear friend, Professor Wesam Ismail. We always enjoy her presentations and her comments on the pathology, one of the pillars of nephrology pathology in Egypt. And of course, having Professor Hussein introducing me, he is Kawkab al-Sharq. He is the light of the Middle East in nephrology. I know his voice is not that beautiful, but he is a beautiful man. Let me introduce Dr. Medhat El-Awady. He is a consultant nephrologist now. Dr. Medhat graduated 1997. He worked in Police Academy, and then he came to work with me in Nasser Institute for 5 years, from 2001 till 2005, where he got his master's degree in medicine. And then he traveled to Kingdom of Saudi Arabia. He worked in El Hada military hospital in El Taif. And also I enjoyed working with him there for 3 consecutive years as a locum. So my training and my friendship extended for another 3 years. And then he came back to Egypt. He got his MRCP from London, and then MD from Al-Azhar University 2010. And he worked first as a lecturer of internal medicine in Aswan University, but then he quit and came to Cairo, where he worked as a consultant nephrology, and then the head of nephrology department in Wadi Elneel Hospital. He's also working in Police Authority Hospital and head of clinic complex in Misr International University. And I did know that he is going to leave Egypt to work permanently in United Kingdom very soon, inshallah. We hope him well. Dr. Medhat, now the mic is yours to start the case. Please, Dr. Hussein, stop sharing and let him share his slides.
Unmute yourself, Dr. Medhat.
Thank you, Dr. Magdy. My godfather in nephrology. So it's a great pleasure to me to share my case with you. Thank you very much for this great chance.
You're welcome.
We will start straight away. Our patient was a 60 years old male patient who was, as his usual state of health, until a few weeks back before the admission, when he noticed general fatigue, exertional dyspnea, and some bony aches, in addition to the sense of being unwell. This was very frustrating to the patient. That's why the patient came asking for admission. Please help me, I'm not well. All of these problems were slightly progressive in course, and it was over around 1 to 1.5 months prior to admission. His past medical history was type 2 diabetes 10 years back, and hypertension 6 years back. And he had, over the last year, a history of recurrent pancreatitis. And he was labeled as chronic pancreatitis and was complicated with chronic diarrhea. And he was on regular follow-up with the gastrointestinal tract team. He has history of recurrent prostatitis as well over the last 6 months before admission, for which he was receiving frequent courses of antibiotics by the urology team for this recurrent prostatitis. He is non-smoker, he is non-alcoholic. His drug history was insulin, ARB for hypertension, aspirin, vitamin B, and loperamide for the chronic diarrhea. He was not taking any of incretin-mimetics as a possible cause for the pancreatitis he developed before. He was not taking any of them. The family history was positive, and this was one of the causes that made the patient panic. His father had diabetes and complicated with diabetic nephropathy, and he started hemodialysis, and he died after 2 years of initiation of hemodialysis. And this event was when his father was 60 years old. So it was around the age of the current age of the patient. That's why, and as we will see, his creatinine started to go up. So he was panicked a little bit of going to the same scenario of his father, and he's going to die soon. Clinical examination revealed he was fully conscious, cooperative, fully oriented. His hemodynamics were very accepted, blood pressure 140/80, pulse rate 90 per minute, and was regular. He was afebrile. His oxygen saturation was a little bit on the low side, 91, 92% room air, and it was resting. His body weight, 90 kgs with BMI of 28. Clinically, he was a little bit pale, but no jaundice nor cyanosis. By general examination, also, he had right cervical lymphadenopathy, and chest examination revealed bilateral basal fine inspiratory crackings. Heart examination revealed no murmurs, no additional sounds, so it was only S1 plus S2 plus 0. Abdominal examination at the time of presentation was lax, and it was not tender, and there was no ascites. Lower limb examination revealed bilateral mild to minimal lower limb pitting edema, and there was no any evidence of peripheral vascular disease, no Charcot foot, and no diabetic foot changes. CNS examination revealed full normal motor system. Posterior column was completely intact. However, the peripheral nerves showed some sort of peripheral neuropathy in both lower limbs. Actually, it was less than stocking. This was the first set of investigation that was done for the patient, and it was found that his blood sugar was 140. This was random. His CBC a little bit abnormal. His hemoglobin was 9. White blood cells was normal. However, the platelet was a little bit low. It was 110, 120 around that.
السلام عليكم دكتور مجدي. والاسامي دي حضرتك كان المفروض ريم مزوداها في اخر.
Okay, so the random blood sugar was fine. The CBC showed anemia. It was normal actually. White blood cells was normal. Platelet was in the low side around 110, 120. His serum creatinine at admission was 2.9 milligram per deciliter. However, it was 1.6 milligram per deciliter 7 months back, and about 1 year back it was 0.7. Urea was 90, uric acid 7.2. His sodium and potassium were a little bit in the low side, and of course, as we said, he had chronic diarrhea, so these a little bit low levels of sodium potassium may be explained by the chronic diarrhea he had. Blood gases showed pH of 7.3, bicarb 19, anion gap was 14, and oxygen saturation, again, it was 91 room air, and it was resting. His amylase and lipase a little bit elevated, and his liver function, ALT and AST were normal. Albumin a little bit low, 3.1, total bilirubin 1.3, a little bit high, and alkaline phosphatase gamma GT a little bit high. So all those with the possibility of the chronic pancreatitis he had over the last 6 months. Chest X-ray, because the chest auscultation revealed bilateral basal inspiratory crackle, so the chest X-ray done upon admission showed bilateral basal opacities, and ultrasound, which was done upon admission, showed no gallbladder stone as a possible cause of chronic pancreatitis and no dilated intrahepatic biliary radicals. However, the pancreas was significantly prominent, the head and body was significantly prominent, and the kidney was a little bit big in size. It was 14 centimeters, both kidneys with no obstructive changes, and the prostate was a little bit enlarged. It was 45 grams. So the patient, upon the clinical presentation and the panic attack he was on, and the general examination and the investigations, I think he was, it was investigated, it should be investigated more and more. So he was offered admission for further investigations. After admission, more deep history and examination revealed by the nephrology team revealed that the patient was not oligoanuric. He had a fair oral fluid intake and average urine output. He had no loin pain, no dysuria, no hematuria, and no recent use of any herbal or nephrotoxic medications. However, I'm announcing about the frequent antibiotic courses he received for the recurrent prostatitis by the urology team. He had no hemoptysis, and he developed only dry cough and exertional dyspnea over the last 4 or 6 weeks. He has no history of arthralgia or arthritis, no skin rash, no fever, no night sweat, but the patient significantly losing weight. And it was claimed to the chronic pancreatitis, and malabsorption may be the cause of his losing weight over the last 6 months. So based on the initial examination and investigations and history, there is a big list of differential diagnosis of the cause of the coexisting renal impairment in this case. It's obvious that it's not a localized renal problem. He had multiple problems. He had general fatigue, he had weight loss, he had shortness of breath and dry cough, he had chronic pancreatitis, he had also chronic prostatitis, and recently he has developed deteriorated kidney function. So it's something global, I think it was upon admission. So is it pre-renal? Any nephrologist here that he has a patient in ER with deteriorated kidney function or acute on top, and he has chronic diarrhea, so the first diagnosis will jump to the mind that he may have pre-renal. So is it a possibility here? Is it a progression of diabetic nephropathy? He has 10 years history of diabetes. He has a strong family history of diabetic nephropathy and end-stage renal disease for his father. Is it a scenario here? Is it immunological based process, including the pulmonary renal syndromes? He has chest symptoms and he has recent deterioration of kidney function. Is it granulomatous disease? Could be a possibility because he has lymphadenopathy, he has chest symptoms, and he has renal impairment deteriorated over the last or recently. That's why it's a possibility. He's 60 years old, so the onconephrology and diagnosis or the possible of any underlying onconephrology case, I think it's possible also, including the monoclonal gammopathy of renal significance. And finally, as we saw in the admission, CBC of admission, the hemoglobin was low and the platelet a little bit low, and he had frequent history of diarrhea. We claim it to be secondary to the chronic pancreatitis, but we don't know based on the low platelet and hemoglobin level. Is it microangiopathy? Is it in the area or not? That's why a little bit big differential diagnosis, and we will see. So the next set of investigations done and revealed white blood cells of 50 to 60, and red blood cells was 10 to 15, albumin in urine +2, and the urine culture sensitivity was negative. So clearly we have here a sterile biuria. Don't forget that the patient has a frequent and recent history of antibiotic use for the chronic prostatitis by the urologist. And even chronic prostatitis can cause sterile biuria itself. So is it tubulointerstitial nephritis? So all of this is a possibility. But he has also red blood cells 10 to 15 and albumin +2. His 24-hour urine collection for total protein revealed total protein of 1.8 grams. His calcium was 8. So if we talk about gammopathy or sarcoidosis, for example, in this patient, and we are looking for hypercalcemia. Of course, hypercalcemia, if it's not there, it will not rule out. You know, hypercalcemia present only in 20-25% of myeloma cases. So hypercalcemia will not rule out. But in this scenario, this patient has chronic diarrhea and he has malabsorption syndrome. So we cannot label now the normal serum calcium or near normal. We cannot claim that there is no hypercalcemia because maybe the calcium on the low side or within the normal because of the steatorrhea or the chronic pancreatitis he had. His phosphorus level was okay. His parathyroid hormone was elevated to 190. CRP was fine. ESR 60. LDH was a little bit high. And the peripheral blood film, which was done searching for fragmented RBCs, it was done twice. It was negative in the 2 times. So no fragmented RBCs. The immunoassay done, and it revealed ANA was weak positive. And again, it was double checked. It was weak positive 2 times. But the rest of the immunoassay in terms of anti-DNA, anti-Smith antibody, anti-Rho, anti-La, anti-cardiolipin, and the rheumatoid factor all were negative. In addition, the anti-streptolysin, ANCA, anti-GBM, all these immunoassays were negative. However, the C3 of the complement was consumed, and again, it was double checked. It was significantly consumed C3. His virology markers were completely negative. Coagulation cascade, PT, PTTI, and are normal. And the hemoglobin A1C was quite good. It was 6. And his fundus examination done and revealed no diabetic retinopathy changes. Echo done for him, and it revealed fair ejection fraction of 55%, and there is no segmental motion wall abnormality and normal pericardium. We requested him high resolution CT chest, which document the presence of bilateral basal infiltrates, interstitial infiltrates, a high suggestion of IPF or interstitial pulmonary fibrosis, and it gives the sound to the clinical finding, which was here upon admission with the bilateral basal inspiratory crackle. So he definitely has IPF. And as I said, upon admission, he has right cervical deep lymphadenopathy, and when we offered him ultrasound neck, it revealed bilateral deep cervical lymphadenopathy. So to sum up the findings till now, he has chest pathology in terms of IPF. He has bilateral deep cervical lymphadenopathy. He definitely has chronic pancreatitis and chronic prostatitis with acute deterioration of kidney function over the last few months.
Dr. Medhat, yes, this is I like this slide because I would like to leave 2 minutes for the audience from my colleagues to write their differential diagnosis in chat, just writing in the chat, and
sure.
then to go ahead for continuation of the case. So we will stop the recording for 2 minutes until we have the feedback from the chat.
Of the medications, not the type of the medication.
Okay. He was in insulin, basal and bolus insulin. By the way, this case was at December 2019, before the era of the coronavirus. I don't remember exactly the name now, but as I remember, he was in basal and bolus insulin for diabetes, and he was on, I think, candesartan, I think, for the hypertension, and he was on vitamin B for the peripheral neuropathy. He was on loperamide for the chronic diarrhea, and he was on aspirin. This was all his weight. The name of antibiotics received by the urology team, it was different actually. He received many courses before admission, maybe 3 or 4 times by the urology team, by the recurrent prostatitis. I don't remember exactly what was the antibiotics received.
I think, Dr. Medhat, the question of Professor Ahmed Adam about the action. What was the action when creatinine rose up from 0.7 to 1.6 6 months ago? Was the case under your surface, or it
no,
was?
No.
Okay.
This case was actually on regular follow-up by the urology and the gastroenterology team. He had this chronic pancreatitis, and every now and then he's admitted with severe abdominal pain. It captured the scenario, the severe pancreatitis and acute abdominal pain, it take the capture of the attendees or the treating physicians.
So the patient was referred to you in
Yeah,
in
because
final
of the pancreatitis now, yeah.
Okay.
Again, what about the diabetic retinopathy, Medhat?
Diabetic retinopathy?
Yes.
Yeah, I mentioned that we did him fundus examination and it revealed no diabetic retinopathy changes.
And this is very
Important.
Yeah, it's mentioned.
also one important question. What was the diabetic and the blood pressure control?
Yeah, here I went back.
Regarding diabetes and hypertension?
Yeah, I went back to the slide here. I think it's now in front of you. The hemoglobin A1C was 6, and the random blood sugar at admission was 140. So the blood sugar was all right. And the blood pressure at admission was 140/80, and all through was a little bit controlled. So there is no big deal with the blood pressure or the blood sugar upon admission and after that.
Yes, Professor Adam wrote on the chat, it is not diabetic nephropathy classic. It may be non-diabetic kidney disease on top of non-diabetic kidney disease in diabetic patient.
Yes.
So absence of retinopathy. And another question, was there macroscopic or microscopic hematuria?
No, it was microscopic. The patient,
yes.
Yeah,
okay.
we asked him many times. He denied any macroscopic hematuria, and upon admission, as we saw, he had 10 to 15 red blood cells in the urine exam. So it was definitely microscopic hematuria.
So the audience wrote in the differential diagnosis, sarcoidosis, malignancy, IgG4 related disease, and the majority agreed about to proceed for kidney biopsy.
Yeah, fair enough.
And this is glomerulopathy, another differential diagnosis. So between glomerulopathy, between IgG4, sarcoidosis, malignancy, so the differential diagnosis is valid. This is why biopsy is indicated to reveal the diagnosis. So please go ahead, Dr. Medhat. Yes.
No, I have a comment first.
Okay.
Also, there was a mention of hepatitis C and B. I think they are negative, of course.
Yeah, all virology were negative.
Yeah. I think my comment, this is the patient that should be biopsied. This is a diabetic patient that all nephrologists should biopsy. We shouldn't hesitate to take biopsy in such patient. He has all the reason to take the biopsy. I think Professor Wesam will agree with me on this.
And there is a large kidney. So
yes.
this is and so this is not the early stages of diabetic kidney disease. So we should do biopsy for this case.
Dr. Sam, we can't hear you. Unmute yourself.
It's unmute. Can you hear me now?
Yes, yes, please.
And it's a frank acute kidney injury. I mean, from 0.7 to 1.6. Even if we have consideration of diabetic nephropathy, we do have clinically a frank AKI, which cannot be expected. There is someone who's insisting on a lymph node biopsy on the chat, and I don't understand what would the lymph node biopsy add, except if we are doubting a lymphoma, for example, but then it's not going to reflect what's happening within the kidney. We're not going to know.
Okay.
So if we're going to do an invasive procedure, then better the kidney biopsy.
So, Dr. Sam, Professor Adam said that biopsy is already late by 6 months.
Because the case was not under the surface of nephrology.
I know, but would you biopsy after 6 months of presentation or not?
Yes.
Is this for me or?
Yes.
Yes, of course. It depends on the original disease, but it's always worth the shot. I mean, if you were considering crescentic or an ANCA or a small vessel vasculitis, which could have been a scenario, yes, probably then you're not going to get a conclusive result. But with other diseases, you will probably get some information which is going to tell you what is going on.
Yes, I totally agree again.
Professor Magdy,
yes.
We have two professors, eminent professors, raise their hand. Professor
okay,
Dawlat,
you can unmute them.
Yeah, and Professor Dawlat and Professor Riyad Saeed.
Okay.
Professor Dawlat Bilal, unmute yourself, Dr. Dawlat. So Professor Riyad, unmute yourself, Professor Riyad.
Here.
Yeah, it's okay. Dr. Riyad.
مساء الخير.
Yeah, no, Sam.
I think it's a very interesting case. We agree that this should be biopsied, large kidneys, absence of retinopathy, low C3, hematuria, proteinuria, all that not part of diabetes, acute deterioration of kidney function that we have, as Wesam mentioned, all that's really considered for a kidney biopsy. Don't ignore low C3 in this patient. I'd like to bet something, you know, with lymph nodes, with high ASR, high active, what we call absence of ANA, DNAs, everything really for vasculitis workup is negative. I'd like to bet most likely there is something related to immune globulin disease, immune globulin deposit disease in such patients, C3 nephropathy with possible underlying neoplastic disorder. Definitely this patient is quite anemic and out of proportion to the degree of renal functional impairment. Biopsy is going to show some element of proliferative GN with C nephropathy in it, and most likely, I'm not going to, I heard Wesam mention something, but I'll keep it to the end. But biopsy should be done immediately as soon as possible.
Full agree with Professor Riyad Saeed and Professor Dawlat.
Professor Dawlat.
Yeah, I fully agree with Professor Riyad Saeed. This is some sort of glomerulopathy, but in the same time, we should not ignore the lymphadenopathy. Deep cervical lymphadenopathy in this age, we need a biopsy from there. It's completely safe, and it might show lymphoproliferative disease and a secondary glomerular disease.
It's a huge kidneys, large kidneys, 14 centimeter kidneys. Yes.
2 biopsies, that's kidney biopsy and lymph node biopsy.
Okay, Dr. Faisal Shaheen. Professor. Okay, Dr.
Okay, I think we can resume from here, Dr. Medhat, and then we'll come back to the audience for the discussion.
Okay. Do agree and very happy with the comments because this what was happened exactly. So if we go back to the first slide upon admission and the differential diagnosis of the renal impairment in this patient, again, to make sure what will be on the top of the list. So is it pre-renal? I think pre-renal is totally away. His blood pressure was fair. His volume status is very well. He is drinking well. The urinary creatinine ratio. So I think this will go down to the list. Is it progression of diabetic nephropathy? So after what we saw now, it's totally unaccepted. His blood sugar is well controlled. Hemoglobin A1C is 6. Diabetic retinopathy is completely absent with the fundoscopy and the deterioration of kidney function, which is recently occurred. So again, this will go down of the list. Is it immunological based? We have positive ANA. We have complement consumed. We have microscopic hematuria. So it could be a possibility still. Is it granulomatous? Sure, it should be think out very carefully. This patient has cervical lymphadenopathy, or generally speaking, he has cervical lymphadenopathy. He has IPF. So of course, it should be included on the top of the list. And as an oncology case, is it oncology nephrology? Yeah, it's really a possibility, and I think it should be ruled out. Microangiopathy completely ruled out by the double checked peripheral blood film for fragmented RBCs, which was negative. So now I think basically we are thinking in the same track. Is it onconephrology case? Is it granulomatous? Is it immunological based disease? I think these are on the top of the list. What was done next? We did. I do believe that when I'm afraid of like gammopathy or this track, I prefer the full package. I mean to do serum protein electrophoresis, to do immunofixation study, and to check for the light chain levels. All we're done, I used to do request the whole package and then pass it to the hematology team for interpretation and for diagnosis and plan. This was happened to this patient, and electrophoresis was normal, and the light chain was a little bit increased, and there is a mild increase in IgG kappa spike by the immunofixation, and the kappa lambda ratio was a little bit increased, but of course we all know that it's not reliable in patients with renal impairment. This package was passed to the hematology team, who insisted and asked for bone marrow biopsy for this gentleman, and bone marrow biopsy was done, and it revealed no myeloma, no leukemia, so the bone marrow was completely free. Serum ACE was not done, and ultrasound kidney biopsy was done. I will jump to the findings and the renal diagnosis and the whole diagnosis, and then Dr. Wesam will give more details about the pathology. So it's very clear the tubulointerstitial nephritis had much infiltrates in the interstitium, and the plasma cell rich infiltrates in the biopsy, and the evidence of fibrosis by the trichrome stain, and the immunofluorescence which revealed IgG positivity in the tubule and interstitium. And actually we get back the renal diagnosis of the biopsy by our pathologist that this gentleman has a tubulointerstitial nephritis with interstitial steniform fibrosis. He has plasma cell rich infiltrates, and he has predominancy of IgG4 positive plasma cells with the plasma cellular immune staining for IgG4, and there was no granulomatous lesion. So the renal diagnosis which was achieved was IgG4 related tubulointerstitial nephritis. And finally, we had offered him lymph node biopsy from the cervical. It's, you know, it's, as said, easy and very, I mean, it's not a complicated issue. So we offered him a lymph node biopsy and revealed no lymphomatous changes. And again, there was IgG4 positive plasma cell rich infiltration together with the steniform fibrosis. So the final diagnosis for this gentleman who had acute deterioration of kidney function, sterile biuria, microscopic hematuria, interstitial pulmonary fibrosis, chronic prostatitis, and don't forget the large sizes of the pancreas and the kidneys. The pancreas, if you remember in the ultrasound upon admission, was very bulky, and the kidneys was 14 to 15 centimeters meter both. So all of these could be packaged in the title of IgG4 related disease. During the admission, his blood pressure was quite controlled, blood sugar was kept controlled, urine output was fair, and the creatinine before starting treatment was ranging around 3, and he was actually fully managed in a multidisciplinary way. Pulmonologist was sharing, hematologist was sharing, endocrinologist, gastroenterologist was sharing in addition to the nephrology team, and the patient was started treatment on oral steroid 40 milligram per day after discussion with the patient about the findings and the final diagnosis and the impact of steroid on his whole scenario and comorbidities, and of course the possible side effects of the steroid, with the need of meticulous control of the blood sugar and blood pressure together with the steroid. So before the second part of the talk, I think Dr. Wesam can...
would you please, Dr. Medhat, to continue your home messages, and then we'll go to Professor Wesam for clarification of the pathology?
Okay.
Because I think it's you finish, and then Professor Wesam, and then to hear from Professor Magdy and from our professors and colleague, and then go ahead, please.
Okay. So we have a lot of take-home messages. It may be 5 or 6 items. I will start with a very quick outline of IgG4 related disease. It's really a systemic or a global disease. It's a disseminated, looks like vasculitis, disseminated malignancy. It's highly disseminating and can affect actually any organ. So it's a fibroinflammatory condition that may affect many organs of the body. And the core of the IgG4 related disease is the organ infiltration of the IgG positive plasma cells in the different organs. And if we can see, it may affect the eyes, causing the orthoxide tumor, may affect the glands, lacrimal and salivary, looks like jugular, looks like sarcoidosis. It may affect these salivary and lacrimal glands. Of course, it can cause IPF, the patient had. I highlighted the yellow color for the complications that the patient had. So IPF he had, it can cause constrictive pericarditis, and of course it can cause autoimmune chronic pancreatitis, and this was happening to the patient. It can cause sclerosing cholangitis. For the renal issue, there is a big comorbidities or complications that may develop from IgG4 to the kidney. It can cause tubular interstitial nephritis. It can cause membranous nephritis, chronic prostatitis, and of course, it can add or lead to retroperitoneal fibrosis that could be complicated with obstructive uropathy. It can affect thyroid gland, causing Widens thyroiditis, and it can cause lymphadenopathy. So all the yellow highlighted complications our gentleman had. There are 3 diagnostic criteria for the IgG4. Actually, the number 1 is the swelling organ. You have to have a swelling organ, 1 or more swelling organ. And number 2, the serum IgG4. I don't believe actually in this serum IgG4 in the reliability or the importance for diagnosis, because it may be normal in patients with IgG4 related disease up to 40% of cases. And number 3 is the tissue diagnosis. And you have to have at least two tissue diagnoses. So in our patient, we had the lymph node biopsy and we have the kidney biopsy. And for diagnostic criteria, if you have the 3, this is a definite diagnosis. If you have number 1 and number 3, it's a probable diagnosis. And if you have number 1 and number 2, it's a possible diagnosis. So for me, the enlarged organs is a core. And like our patient, the pancreas and the kidney, and the tissue diagnosis is the core as well. And we had the lymph node and the kidney biopsy. And of course, the treatment is only steroid, around 0.5 milligram per kg per day, for around 4 weeks, and then consider the gradual withdrawing. And for the steroid-resistant cases, we can try or we can discuss the possibility of using rituximab. However, the rituximab is highly effective in these cases when the pathology is membranous nephropathy rather than tubular interstitial nephritis. So the IgG4 subclasses going up now, and it's very important not only to know its IgG, but also to know which subclass of IgG. And if you remember the membranous nephropathy, it's quite important, the different classes in different types of membranous nephropathy. But the strange here in this disease is that IgG4 is the least subclass in quality and the least subclass in quantity. I mean, it's only up to 4% of the total IgG classes. So it's very minimal in amount. And in addition, IgG1, 2, 3, very strong pro-inflammatory and can cause macrophage and complement activation. However, IgG4 is not. So IgG4 is the least amount, the least class amount, and the least class ability for macrophage and complement activation. So how come this week IgG4 will be the responsible for the whole dilemma and this big systemic disseminated complications of IgG4 related disease? It's a little bit weary. And that's why some are suggesting that IgG4 is not the real cause of the problem. However, it could be only fingerprints of the real pathology that's still not well understood. Few points about tubular interstitial nephritis. It's not always drug-induced. There are many other causes of tubular interstitial nephritis apart from the drug-induced. I mean, you can see many patients with atypical pneumonia because of mycoplasma or Legionella and presented with tubular interstitial nephritis. I have a patient with Sjogren's and complicated with tubular interstitial nephritis. So I mean, it's not always drug-induced, and we should think about other causes of tubular interstitial nephritis. When the cause is non-steroidal anti-inflammatory drugs, actually these drugs are antibiotic drugs and anti-inflammatory. So if it is the cause of tubular interstitial nephritis, sure we cannot or we should not predict fever or rash because they actually anti-inflammatory drugs and antibiotic drugs. And in addition, the non-steroidal tubular interstitial nephritis may be associated with nephrotic range proteinuria. And for the TIN post-transplant, again, the tubular interstitial nephritis in immunocompromised patient, on the top of the list will be the infection. And as we have a big topic, highly respected topic, which is called infection-related GN, there is another topic called infection-related tubular interstitial nephritis. So in post-transplant, and because they are immunocompromised, so when we have tubular interstitial nephritis, on the top of the list will be infection, like BK virus or CMV. Tubulointerstitial nephritis with hypocomplementemia, we have to think about IgG4 related disease or tubulointerstitial nephritis with uveitis. When we see in the urine analysis microscopic hematuria, we usually think about the glomerular injury, but I'd like to highlight that tubulointerstitial nephritis may be presented with microscopic hematuria, and even with red blood cell cast, it may occur. The urine eosinophils, actually, I'm one of the non-believers in the real practice of using eosinophils. It's not specific, not sensitive. So sometimes I believe that it's done only just to say I did something for the patient, I requested him something. But in many scenarios, its negativity means nothing and its positivity means nothing. The MMF used in tubulointerstitial nephritis, I think it's a point for discussion when steroid is not recommended from the start, or when it's refractory. So we'd like to highlight the evidence of the use of MMF in tubulointerstitial nephritis and for how long as well. Single word in the plasma cell cells reach infiltrates. It's very important to know what type of cell are taking a big population in the infiltrates, because it differs, or it directs you for different diagnosis. And here I will not waste time in it, but this is all the causes of plasma cell infiltrates reach infiltrates. This is, I like this couple of slides about the complement, because it's the unwelcome guest for nephrologists, this complement. So sometimes you have a renal problem because of a direct complement effect. And we can see this in C1q nephropathy, C3 nephropathy, complement-mediated HUS. But the other point I'd like to highlight is, yes, the complement is associated or involved of many immunological diseases. And most commonly, it's involving the glomeruli. But at the same time, there is many active immunological glomerular diseases with normal serum complement. And we saw this in Good-Vascular syndrome, for example, Henoch-Schönlein purpura, etc. So again, normal complement should not rule out any active immunological glomerular disease. And not only glomerular, patient may have immunological based problems, but non-glomerular. And here you can find the hypocomplementemia with non-glomerular lesions. And we see this as in our patient here, IgG4 tubulointerstitial nephritis, and in tubulointerstitial nephritis with uveitis. So it's complement consume disease, immunological, but it's non-glomerular. I'd like to highlight that not all hypocomplementemia state because of immunological based problem. There are many other causes, non-immunological, and could be associated with a significant complement consumption, like atherosclerotic diseases, acute pancreatitis, severe liver disease, severe sepsis, severe malnutrition. So there is a big other package of causes that non-immunologically can cause complement consumption. The question is hypercomplementemia of any clinical value? Is it important? Does it mean anything? For my knowledge, no. But it's important to know when the serum complement is high, like pregnancy. During pregnancy, there is many physiological changes. One of them, the complement is going up. The importance of this item is only to know that normal complement in this situation is inappropriately normal. And serum complement in this scenario should be high. So being normal, this is a normal result, but not a normal value. So the normal complement in pregnancy may mask active underlying immunological disease. This is my last slide about demopathy. I'd like to highlight something, that the protein electrophoresis up to 11 to 15% of patients with myeloma is normal, because the threshold of serum protein electrophoresis is different. I mean, it can detect demopathy only if the M-band going more than 0.5 gram or more than 500 milligram. But below this, it will give you a negative result, and it's not normal. That's why immunofixation is more sensitive, and you can detect as low as M-band, as low as 150. And of course, the serum light chains and the ratio is not reliable in renal impairment. But if somebody need a number to be corrected number in renal impairment, so the normal ratio under renal impairment is around 3. So if the normal is around 1.6 with normal kidney function, so either you don't request it or don't rely it with renal impairment. But if you ask for it and you'd like to rely on it, the normal at this circumstance will be 3, not 1.6. Thank you very much, Dr. Hussein.
Thank you very much, Dr. Medhat. It is an excellent case, excellent presentation. And I'd like to leave the mic to Professor Magdy El-Sharkawy to run the moderation.
Yes,
Dr.
it's a very, very interesting case. We usually don't see such a diagnostic tools to reach to this patient, because this patient belongs to gastroenterologist, because he has a pancreatitis, and they know that autoimmune pancreatitis is sometimes due to IgG4. They should diagnose the patient before coming to nephrology with interstitial nephritis. Yes, Medhat, you raised your hand.
I'd like to comment on that I conducted the gastroenterology team, and they requested him 3 times the serum IgG4, and it was normal. That's why I hate this serum.
Again, this does not exclude the diagnosis,
Yes,
because
yes.
if the patient is not alcoholic, if he doesn't have gallbladder stone or other reason for autoimmune pancreatitis, they should think, and sometimes they take a pancreatic biopsy. They shouldn't wait for this patient 1 year with pancreatitis until he develop interstitial nephritis and acute rise of his creatinine. This is one. Also, the lymph node should with pancreatitis, it should drag the attention to this kind of disease. Also, I like what you did. You didn't start treatment with steroid before you diagnose the patient well, because steroid will complicate his diabetes and blood pressure. Before going into more discussions, I'd like to hear from Professor Wesam Ismail, her opinion about IgG4 nephropathy, and how many cases has she witnessed, and what is the most reliable way to diagnose them through renal biopsy. Professor Wesam.
Okay,
Dr. Medhat, would you please stop the share of your slides to allow Dr. Wesam to share her slides?
Yes. Stop share, okay.
Dr. Wesam, please share your slides.
Okay. Okay, I'm not going to talk a lot, but as Dr. Medhat beautifully illustrated, this is a systemic disease, and this is why we do call it systemic IgG4 related disease. And as also was mentioned, that the tubulointerstitial nephritis of this part of this disease is the most severe form which can occur in these patients. Classically, this is how IgG4 looks like. And actually, when you catch it within this stage, you get more or less a characteristic light microscopy picture. So you have this plasma cell-rich infiltrate, but there is a background of something going on. You can see that this is not your normal fibrosis pattern, nor your normal inflammatory infiltrate pattern, which you see in the kidney. So you can get the disease with more florid inflammation, like here with this background. And even with this florid inflammation, when you look closely, then you can see all of these sclerotic fibers, this early sclerosis. And this pattern is very characteristic because it surrounds the inflammatory cells, as you can see here. So you have it surrounding, so fibrosis starts surrounding the plasma cells here and here. And it gives this characteristic, what we call in pathology, storiform pattern. Sometimes it can form aggregates, but not actually frank granulomas. And this is again within a more inflammatory biopsy, which had more dense sclerotic bands. But again, these sclerotic bands are surrounding the inflammatory cells. So this is really characteristic of IgG4. And once we see it, we think about it. Then patients can have all stages within the same biopsy, or they can present with different stages. This is a more sclerotic form. So when it gets progressed by time, you get less inflammation and more sclerosis. And you can see the remnants of the glomeruli, the arterioles, and what is left of the tubules within this sclerosis. And then you can see again with the high power that even though the inflammation is subsiding, you still maintain the same pattern, just more sclerosis and less inflammatory cells. But they are quite characteristic. Again, you can catch how much the sclerosis is actually surrounding the inflammatory cells and giving this what we call storiform appearance. Look at this. This is really more or less diagnostic of IgG4. This pattern of fibrosis, the storiform pattern of fibrosis, when you feel that it's on levels and infiltrated by or entrapping the inflammatory cells, is actually quite characteristic of IgG4. And then when patients progress, you get more sclerosis and much less inflammation. But in spite of this, this should not be called irregular renal fibrosis, because again, this fibrosis still retains the same pattern of storiform, this storiform pattern. So these patients could be easily diagnosed as an stage renal disease or marked interstitial fibrosis when they are not. The sclerotic pattern should also be recognized as the sclerotic phase of IgG4 related disease. Of course, you can get early cases like this one, for example, where you get an active interstitial infiltrate, which looks like your regular tubulointerstitial nephritis, and also with eosinophils. But again, when you look closely, you can still recognize this pattern. So this is a very uncommon disease. I've seen a total of maybe 8 cases. Maybe it's not regularly, maybe it's underdiagnosed, maybe these patients are not regularly biopsied, maybe it is missed on the biopsy, so we don't have really an actual incident, but it needs to be in the back of your mind within the different diagnosis, at least for pathologists, when we get an unexplained tubulointerstitial nephritis with some chronicity and which is plasma cell dominant. The diagnosis is, or one of the criteria of the diagnosis, as Dr. Medhat mentioned, is the staining for IgG4. You've seen in Dr. Medhat's presentation the immunofluorescence, but mainly for the tubules and the glomeruli. But this is the IgG4 positive cells by immunohistochemistry, as you can see. Again, IgG4 positive cells. This is a more, this was a more florid inflammation. You can see the IgG4 positive cells infiltrating through the sclerotic kidney. Again here, you can see, or the infiltrate, which is IgG4 positive. So the diagnostic criteria by histology is that you get a plasma cell-rich tubulointerstitial nephritis with more than 10 IgG4 positive plasma cells per high power field in the most concentrated field. And you can get plus or minus tubular basement membrane immune complex deposits, and which can be detected by any method. Also, the presence of other organ involvement, like in this case, especially autoimmune pancreatitis, sclerosing cholangitis, and salivary gland involvement, always should make you consider IgG4 if the patient has a renal impairment as well. And of course, there is the imaging, and as Dr. Medhat said, you need 3 out of 4 of the diagnostic criteria to be able to diagnose, and the serology to diagnose this disease. So what we do is that we stain for the regular polyclonal IgG and for the IgG4, and we pick the most crowded or the most focused with a lot of inflammatory cells, and we compare, and as you can see, this is the number of the IgG positive cells, and this is the number of the IgG4 positive cells. So a dominant IgG4 infiltrate is definitely a diagnostic of IgG4 related disease. Before I finish, Sjogren syndrome, it's been mentioned more than once, and I don't think, or at least in my own opinion, and in others as well, Sjogren is considered part of the systemic related IgG4 related disease. It's not in the differential diagnosis, it is part of this disease, and we should recognize it. Sjogren also causes classically a plasma cell-rich infiltrate. So a plasma cell-rich infiltrate in the kidney, we first actually think Sjogren. We don't think monoclonals, because very, very rarely that a myeloma will give you a plasma cell-rich infiltrate. This is not a transplant, so I'm not going to think about a viral nephropathy. So in a native kidney, a plasma cell infiltrate raises the doubt first for Sjogren, and then maybe that this is an IgG4 related disease. Well, thank you. That's all.
Thank you.
If you have any questions,
thank you, Professor Wesam. Dr. Magdy.
Yes, very, very illustrative presentation. Of course, This is a rare disease to be diagnosed. 8 cases from Professor Wesam. This means it's extremely rare. This is an extremely rare condition. And we have to know that this patient, he has a systemic disease. This is not nephropathy. This is a systemic disease that should be treated and should be treated well, because IgG4 disease, it has common relapses and it can damage organs like the pancreas, like the biliary tract, sometimes retroperitoneal fibrosis and retroorbital fibrosis.
I just want to add that I have seen other patients, but not with tubular interstitial nephritis. I had a very interesting patient who had unexplained retroperitoneal fibrosis, another one with an orbital pseudo tumor, and another one which we diagnosed because of her pancreatic biopsy. But these 3 patients did not develop tubular interstitial nephritis. So also it seems, I'm not sure, but it seems that the renal presentation is also less common within these patients. They usually have the lymph nodes and the pancreatitis by the time they develop.
If you allow me, Professor Wesam, I'm going to comment on this point within the closing, because I prepared 3 slides only for IgG4 related disease. So I'm going to highlight the most commonly affected organs within this disease in a minute within the closing. But I would like to ask Professor Wesam, if you allow me, Professor Magdy, Dr. Wesam, if the issue of phlebitis, obliterating phlebitis, because this is one of the stigmata of the pathology of IgG4 related disease. So I'd like to hear from you about the phlebitis and obliteration of the veins within this pathology.
You don't really see a lot of veins within a renal biopsy. This is uncommonly sampled. I'd just like to add that the first, actually, I know you're going to talk about the organs affected, but one of the earliest tissue which is affected by IgG4 are the bile ducts. So these patients usually can present only with unexplained. I have a question or a comment in relation to the case, if you allow me.
Yes, please.
Okay, Dr. Medhat, I loved your presentation, but I do have a comment on the hypocomplementic issue, and that I would not consider within this specific clinical scenario that if I have a diabetic patient with a low complement, with a C3, and a tubular interstitial involvement, that I would not relate them, because it's a diabetic patient and he is very much liable to infection. So I wouldn't really put hypocomplementemia high within this patient. So this was just a comment. I wouldn't, I wouldn't link both. And also I would like to add to the differential diagnosis, as one of the audience also suggested, that lacto amyloidosis could have also been a very valid differential diagnosis within this patient, considering that he's diabetic and he has a rising serum, an unexplained rising serum creatinine. Thank you.
Dr. Magdy, Dr. Ahmed Absalam raised his hand. Do you like to? Dr. Ahmed?
Thank you to
Dr. Muhammad.
Dr.
Muhammad Saeed always changing his names. So I would like, before hearing your comment, I would like to congratulate you for the best organization of NephroAlex. It was very nice, wonderful meeting, including hybrid between e-learning and between the distance education and between real education. So it is fantastic and everything was perfect. So congratulations for this organization. Your comment.
Thank you, Mr. Hussein, for your attendance and for all the colleagues. We are honored to have you with us in Alex. Very nice. But my comment, the association between IgG4 and malignancy at the time of diagnosis and in first year after treatment is very high. For that, I feel at the time of diagnosis and within 3 months after treatment, radiological investigation with CT CAB with contrast or PET scan or MRI is suggested. especially the association with gastric cancer is very high with this kind of patient, and many patients develop malignancy within 6 months after treatment. The second point regarding treatment, you are right about the maintenance treatment, because many patients, they develop relapse and recurrence, and there was a debate, shall we go with maintenance treatment or not? What we usually do, that we taper steroid and we choose between MMF and ASA for maintenance to stop the steroid. For the two comment, the radiological screening before treatment and in the follow-up for monitoring the patient, and stopping the steroid within 3 months and starting either MMF or azacitidine. And thank you so much.
If you, regarding your comments, Dr. Mohammed.
Dr.
Yes.
Hussein, if you allow me to comment, yes.
Yes.
This patient
Yes.
has already several relapses, and such kind of patient, he should be maintained for at least low dose steroid for some period. And there is no evidence that any other immune suppressive medication will prevent recurrence. Not even cyclophosphamide, methotrexate, azacitidine. They were tried as steroid sparing protocols. But for such patient, for this particular patient who have several attacks of pancreatitis, and then he developed lymph node enlargement, and then in severe interstitial nephritis, I think he should be maintained in prednisone for some time, because the relapses are very common and he is already relapsed. So I believe that 2.5 to 5 milligram daily won't harm him if he flasts for some period.
Dr. Medhat.
Yeah, I agree, totally agree with Dr. Magdy and Dr. Ahmed. Yeah, this patient now, he's on 10 milligram.
Muhammad. Okay.
Dr. Muhammad, I'm sorry. Now he is on 10 milligram. And his creatinine is around 1.6, 1.7. And the amazing thing that he was not admitted to the hospital by any pancreatitis attack. And the most important actually is the lifestyle. This patient, when he came to admission, he was highly frustrated. He said, I'm totally different. I cannot go. That's why he has now a good quality of life, no hospital admissions, and stable kidney function. And I agree with Dr. Muhammad that he has a high risk for malignancy, and yes, it's justified for regularly follow-up.
Dr. Medhat, regarding the issue of association with malignancy, it is revised because this was an old dogma. And this is why before establishment of the diagnosis of IgG4 related disease or IgG4 as systemic disease, we should exclude malignancy first. And I would like to confirm the comment of Professor Magdy El-Sharkawy. Steroid is the marvelous drug for IgG4 related diseases, to the extent in the exclusion criteria of IgG4 related disease, there's some thinking of steroid resistance as an exclusion for the diagnosis. This is why the best treatment is steroid. And I remember a funny case. It was not IgG4 related disease, but it was a case of retroperitoneal fibrosis associated obstructed kidney. So I started steroid based on the radiological evaluation and the presence of hydronephrosis within the kidney. And the retroperitoneal fibrosis responded well to steroid therapy. And because of the patient was afraid of steroid toxicity, he stopped the steroid. Again, a relapse of the retroperitoneal fibrosis and a relapse of obstruction, and then we repeat the steroid again. So even in retroperitoneal fibrosis, steroid and immunosuppression may be the line of treatment. Dr. Magdy.
I totally agree, Dr. Hussein. This is one of two diseases that if they don't respond to steroid, it is undoubtedly diagnosis. The other one is, of course, giant arthritis. So if the patient is not responding, this is not IgG4. I totally agree, yes.
Dr. Magdy, do you like to have some comments from our audience?
I'm waiting to hear the final report from, as usual, Dr. Hussein.
Okay, so if any one of my professors and colleagues want just to add any comment, please raise your hand, and then we are going to hear from you after just a couple of slides. So I agree with Professor Wesam that Dr. Medhat El-Awady was excellent presenter.
Thank you.
The case was very nice. You tackle it by a very good way, but Dr. Dawlat Bilal raised her hand So before proceeding, I'd like to hear from Professor Dawlat, her comments. Dr. Dawlat.
Thank you very much, Professor Medhat, for the presentation. It was very analytical and very informative. Thank you very much. And I have a question for Wesam. In the first few slides, I saw glomeruli surrounded by fibrous crescents. So is there an element of glomerulopathy as well? And that's why he had a proteinuria of 1.6. Correct me if I'm wrong. What I saw are glomeruli with fibrous crescents, right?
Dr. Dawlat, no, these were not fibrous crescents. This is just periglomerular fibrosis. But
So,
due to the
so not mainly tubular, not only tubular interstitial.
No, it is only tubular interstitial. These are not crescents. This is just periglomerular fibrosis from the extent of the tubular interstitial scarring. And we don't go for anything called fibrous crescents. If I don't have a cellular crescent, then there is no crescent.
All right. So the glomeruli are also infested with these plasma cells?
No. These were just ischemic. The pictures I showed are not the biopsy of the case. And the patient, as I understood, had less than 1 gram albumin creat ratio, protein creat ratio, right?
Yeah. Right.
Yes, protein creat ratio. And he had a more or less, I guess, a proper serum albumin level. Is that correct?
3.1. That's 3.1. Yes.
Yes. So I think that just the 900 milligram were caused by the tubular interstitial nephritis rather than a glomerular disease.
Yes, and I just want to note that 1.6 gram does not fit with amyloidosis. Amyloidosis usually gives me very high protein, very heavy proteinuria. I know the cases are large and they are such
of amyloidosis. Since we are discussing a diabetic patient who's presenting mainly with an AKI, we were considering leukocyte chemotactic factor or LEC2 amyloid, which is mainly tubular interstitial. So it is accepted to have a minimal or even no proteinuria within these patients. So regular AL amyloid or AA amyloid. So this is also it's only this specific type of amyloidosis which can be within the differential diagnosis of this case.
Right. Thank you.
Thank you, Professor Dawlat. Thank you very much. Sometimes IgG4 related associated with membranous and the other and vasculitis, and so we may find cocktail of glomerular affection with tubular interstitial nephritis. I'd like to, yes.
But we I haven't seen it.
Yes, okay.
It's reported, but I think that maybe it's only because the primary membranous is IgG4 positive as well. So all our
association.
Yes, all our cases we did investigate for membranous thoroughly in case it could have been missed within the TIN, but we never found one. Maybe you just did not meet one yet. Okay.
Okay. Thank you very much, Professor Wesam. It was a very wonderful case from Dr. Medhat, and the commentary of Professor Wesam is very interesting and clarified the issue of IgG4 related disease. Thank you very much for your informative slides, Professor Wesam.
Thank you.
I'd like to thank Professor Magdy El-Sharkawy for his moderation. And in a few minutes, this just to show you that this is a systemic disease. And this is from the update of Nature Review Rheumatology. As you see here, all these are manifestations that may be encountered in IgG4 related diseases, not kidney, it is a systemic disease. So if we have the whole human body from the crown to heel, you can find manifestations. But the most important point in this slide is the color. What is the code? This is a color, and this is one, and this is the third one. So this color denotes frequent affection. So in the systemic disease IgG4, when we have major salivary glands, asymptomatic enlargement, usually symmetric, pancreas. So this is why in pancreas we should be very careful. And I would like to congratulate Dr. Medhat for repeating IgG4 for many times, because diffuse enlargement, presence of diabetes, endocrine insufficiency, all these can be considered the manifestations of this disease. Erythroperitoneum, soft tissue mass encasing the anterolateral aorta. Lacrimal gland asymptomatic enlargement, usually symmetric. This is why there is, as Professor Wesam mentioned, there is a link with Sjogren's syndrome. And for the occasional lesion, this color, lungs, masses, nodules, bronchial wall thickening, bile duct, intrahepatic and extrahepatic strictures, kidney, focal masses, usually multiple, bilateral, and tubular interstitial nephritis, as shown from Professor Wesam, is already known. And for this color, which is infrequent, the award, this infrequent, Becky meninges is infrequent, and the thyroid gland asymptomatic enlargement, usually symmetric, is infrequent or rare. So this is the whole spectrum of the systemic disease by the incidence: frequent, occasional, and infrequent. If you'd like to read in details the characters, how to diagnose, please go ahead and review this article, because this is the 2019 American College of Rheumatology European League Against Rheumatism classification criteria for IgG4 related diseases. And they started by exclusion criteria, a lot of exclusion criteria first, and then inclusion criteria. And at the end of the day, there is a scoring system. And if the patient has 20 scored, this is with the highest diagnostic efficiency. And this is another article showing the same. So please, if you would like to read about this disease, it was characterized well according to the very large number of patients cohorts reviewed by the Rheumatology Association. Regarding the kidney, IgG4 related kidney disease, this is a cohort of patients, 34 patients. And as you see, pancreas is affected in 60% of the cases, biliary system in 50%, and then you find here the percentage of each organ affection. This is why when we evaluate a case in nephrology, we should put in mind the other system affection, because it may guide us in diagnosis. And don't forget, please, that the diagnosis is based on exclusion. First, excluding malignancy, excluding vasculitis, lupus. So all the points written in the chat are right. We should exclude all these diseases before thinking of this disease. Just one slide about radiology. And this is the problem. We may order CT scan, and CT scan may be suspicious for malignancy. If you look here, this is a very nice study. As I mentioned, 34 cases reviewed by experts in radiology after the diagnosis of IgG4 related kidney disease was confirmed. And they reviewed the radiology for this patient. As you see here, kidney, this is heterogeneous, where the mass is hypodense. And here there's another mass in suprarenal gland in the psoas muscle. So a lot of problems can be found in radiology that needs the expert and how to put the proper differential diagnosis in mind. I don't like to give detailed comments, but I'd like to thank Professor Magdy El-Sharkawy for the excellent selection of Dr. Medhat El-Awady. We enjoyed the presence of Dr. Medhat and his style of presentation, and we hope that he can share us with another case in near future. Even if he left the country, if he will leave to the UK, he can join us through the e-learning style.
Sure.
I'd like to thank you very much, Dr. Medhat. And this is just a symbol, Professor Magdy El-Sharkawy, for this nice organization for the case and for moderation, as well as Professor Wesam. Always, she enriches our Academy of Education. Thank you very much. And Dr. Medhat, really, you are a discovery this night by your very nice and excellent attitude. And I'm going to leave the mic for the final words for Professor Magdy El-Sharkawy.
Thank you. Thank you.
I cannot say anything more than what Professor Hussein He is enlightened us with the last few slides. I'd like to thank Dr. Medhat El-Awady. I wish him the best of luck. I trust him. I know that he is one of the best I worked with. He's presented the case very nicely and very professionally. And the approach was extremely professional, as Dr. Hussein agreed. Of course, Professor Wesam adds a lot to the Nephrology Society. She's a nephrologist, although she's a pathologist, and we enjoy her comments always. And of course, Dr. Mohammed from Alexandria, again, enriched this meeting. I'd like to thank Professor Riyad Saeed, Professor Faisal, Professor Dawlat Bilal, and everyone who shared with us this lovely night. And until next case and next presentation, I wish you all good night. Thank you very much. Assalamu alaikum wa rahmatullah.
Thank you very much, Professor Mary. Thank you all professors and colleagues. And I'm not going to repeat the name of professors, but Professor Magdy forgot Professor Adam because he
Dr.
shared,
Ahmed Adam, of course. طبعا was the first who joined us.
Okay. Thank you all and goodbye. And the video will be uploaded tomorrow. Inshallah.
Everyone, thank you.
Bye.
Thank you.
Thank you.
Thank you.